You can see these teeth are pretty broken down, not a lot of tooth structure left. The ones we get out in one piece, we get out in one piece. The ones that we don't, we go and start to elevate them out. And sometimes we even leave the teeth, depending on how close they are to the nerve and how much bone we have to remove to be able to take it out. No big deal. Now we're reflecting the tissue. Super important to protect that tissue because we're going to need that tissue. As you can see, our tissue is super thin. There I am elevating the tooth. My assistant is working hard to suction so I can see what it is that's going on. Obviously it's a root canal treated tooth. It's very hard to move it, but you can see it's starting to slowly come out. And we'll slowly take it out piece by piece. Yeah, we continue, take off this bridge. And then we slowly take out these teeth, preserving as much bone as we possibly can. We now try to make the bone even from the posterior to the anterior, because the posterior had no teeth and it was actually a huge roller coaster. We create our spade drill at first, lots of irrigation, and then we go and densa everything in reverse to try and maintain as much bone as we possibly can. As long as we're bleeding, we're still okay. This is about a 3.0. I don't go all the way down. This is a 4.1 blue diamond implant that we're popping in. Goes in really fast and quickly, not too aggressive. And then we continue our lingual placement of the osteotomies. This is in the canine position. We use a depth specific drill and then we go ahead and we densa that. This is a SIN 360 Epicut implant. And you can see I didn't drill deep enough so I couldn't get any stability. And I didn't want to go any deeper because she had very interesting foramen around there. So we kept on going up and down different sizes until we finally used the mesial and distal to stabilize the implant. This is a larger size. As you can see, still we're not getting stability. Just had to drill just a tiny little bit deeper. You can see that drop. Try and stabilize the implant. Again, it's a little bit harder, especially with this type of implant, as you go in and out. And then I think I ended up using a 5 and I was able to get nice stability. Continue on here. Depth specific, it's a little hard. Boom, 3.5 SIN, went in straight perfectly. Clean up all the bone. Lots of irrigation. This is running at 19,000. I love the white burrs. They don't get clogged as much. Multi-unit abutments placed. Boom. You can see it moved a little bit. No problem. I repositioned it off the plate. Same thing here. Boom. Set the multi-units in. Nova bone where there's a bone everywhere. Augma to augment the lateral ridge, because as you can see it was pretty thin. We hold everything in place and we don't necessarily expect the bone to grow, but definitely to increase the thickness of the tissue. And we suture everything nice and close. I release where I need to release, but still having lots of tension. And then we start with our first bite. This is a 4.0 chromic suture. This is about the number 19 area, if you can have an idea of where I'm at. Nice tie, cut. Go in front of the multi-unit now, not on top of it, right in front of it. Take the papillas, because now what we're going to do is we're going to hold down the tissue with the THS caps, and that's the beauty of these THS caps. Boom, it will hold the tissue down. And I think after I may have changed this one, because you can tell on this one it's a little bit too tall, because it's not doing its full job, but you'll see it do its full job on the next one, where it holds everything together. Go from the lingual to bring everything buckle. Interrupted. Don't pull all the way. Take out the 2 because that was the wrong size. Come into the front. boom, you can see it pushes on the tissue, and then we finally tie. We'll put a 1 millimeter there, and then we tie it, and you can see I'm going to just slowly tuck it into the bottom of the THS. You'll see that in a second when I finally tie everything back together. But you can see already that's going to be the new position of the tissue. So it's almost like I did a lateral ridge massive augmentation, not just with tissue, but with bone, by just repositioning it and holding it in that position. And we continue, so we have our quadrant on that side done. And I try not to cut any tissue, even if there's all this little papilla. It means a lot to me. Every piece of tissue, especially in a case like this, I try and maintain as much of it as I possibly can. And that's how after you see how much tissue I have. I got a little bit stuck, but boom, my assistant helped me and I tucked it under the THS, and you can see how beautiful the tissue is coming together. The bleeding is basically stopped in that area. And then we go to the next side. Slowly elevate these teeth out. Just try not to break them. That one just crumbled. Crumble, crumble, crumble. But it was loose, so we were able to get it out. Started feeling a little bit on the lingual, so I got her a little bit more numb. Took those teeth out, level it to the level of the THS minus 2 millimeters. Take that last piece not to hit the THS. Clean out that last little piece of tooth that was broken. Yeah. And then we start to drill lingually. We do our depth drill so that I know where we are. This is Syn 360. I think this is a 4.0. Boom, goes in really fast. I love this about the implant. Adjust, adjust, adjust. I get a nice platform for my drill. Place this Syn 360 again, and then boom, we start to place the multi-units. Excellent. Everything is where it needs to be. We augment the bone with some Augma bone. Place the right THS now in the back, which was the 1 millimeter. You can tell via the pink. Keep all this little tissue that most people cut away. We want to keep it where it's supposed to be. Add the 2 millimeter THS right on top to clamp down on the tissue, and then suture it closed to keep it right where it's supposed to be. This is really important. It's super going to help you when you not only take the impression, but when you'll screw in your screw-retained temp or even cemented temp, you know the tissue is where it's supposed to be. When you take off the THS, it's not going to move because you sutured around exactly where it's supposed to be. And all this little tissue will help you. As long as it's got a blood supply, it won't necrose or fall out. And on this one, I wanted to build as much as I possibly can, and only then did I add the THS on top. Because when I don't have enough, then I'll suture it and then open just a tiny bit and put it back together. And you can see again how clean it is. It's not bleeding or anything like that. It's not oozing, and my impression is going to be pretty easy with my intraoral scanner. And in this case, I had a couple of bleeders actually that I had to cauterize and right down in the midline. So that's that. That's what it looks like now, finished. And we take out our trios. We go ahead and we scan them. Obviously, make sure there's no blood. Sometimes in these cases, I want to go ahead and powder it, just because with the tongue moving, the scanner has a little bit of a hard time picking up the scan. Finish that scan. Now we're going to go ahead and control our vertical dimension. We know that it's correct. And once we did that, we take off our THSs, and we're going to go ahead and put on our IO Connects. And this IO Connect is just so that we can confirm that the THS impression was correct. If you're a good scanner and you think that your scan was correct, this is not necessary, but it's always good to be safe rather than sorry after the fact. In the mandible, it's always very difficult to place the THSs because sometimes you have to put them on the buccal, sometimes on the lingual, depending on the angle of the mandible and the angle of the multi-unit. Sometimes it goes a little bit too deep, especially in a small mandible. You sort of run out of time. You can see here I'm using all the smalls. And really the key is when you start with the posterior one, if you pick the right position of the posterior one, then the rest will all fit in. But if you're too anterior with the posterior IO connect, then you'll sort of run out of time and start to fight, as you can see. So in this case, I had to flip it around. Instead of going lingual, I decided to go buccal with the IO connects. And obviously my retractor kept flying off, but we got that nice and back into position. And we go ahead and we scan. This is a sub 6 second scan. Unscrew everything. And then pop all the THSs back on. Obviously the same cuff height, doesn't have to be the exact same one, but just the same cuff height that you placed because the temporary needs to fit on top of that. Boom, we set our temporary with some THSs that are exposed. We lock it in so we don't have to wait for the cement to set. And now we take impression of the temp. Patient theoretically can go home with this. But after we design the temp and print it, make sure everything is in perfectly. Screw it in with power ball screws. We torque it to 15 and boom, the bite is perfect. Clean it up a little bit. Some clip flow in the anterior so that it doesn't fit, it doesn't bother her tongue. Cure that. And that's the whole case. Hope you enjoyed it. Comment below if you have any questions about it.